So good morning. My name is Dr. Karen Greenberg, and I'm here to talk about infection in the elderly, now part 2, which is going to include some topics like influenza, meningitis, herpes zoster, and we're going to touch base about that carbapenem-resistant enterobacter in this part. I'm one of the attending emergency medicine physicians here in South Jersey, working with Virtua, Kennedy, and Capital Health Systems. So again, this is part of the care of the aging medical patient in the emergency room, part of our camper lecture series. And again, thanks for having me to be a part of it. What are our goals after part 2 of this lecture? Recognizing and treating infections in the elderly patient can be particularly challenging because symptoms are often quite subtle and atypical in older adults. In this session, you as emergency medicine residents will learn how to recognize common atypical presentations of various geriatric infections, institute treatment in the elderly with respect to medication dosing and drug interactions, identify admission criteria and appropriate transitioning of care from the emergency department. So I have a new question for you guys. This is a lot of words. A 68-year-old female from the community complains of cough, nasal congestion, and shortness of breath 1 week ago. The patient saw her family doctor and was diagnosed clinically with influenza. Because the patient presented after 5 days of symptoms, no treatment was initiated. The patient now presents to the ED 10 days after initial onset of symptoms with a temperature of 102.6, a productive cough of yellow mucus, and expiratory wheeze bilateral lung basis. Chest radiograph done in the ED shows a left lower lobe infiltrate. Which of the following is the most likely cause of the patient's pneumonia? Is it Staph aureus, Haemophilus influenza, strep pneumonia, Legionella, or Mycoplasma pneumonia? And you guys are all going to get it right from the first part of the talk, right? Ooh. Wait, what happened? All right, we'll get it right the second time through. Okay, that's fine. How about this one? Regarding infection in the elderly, which of the following statements is true? Is it A, most cases of fever and infection in the elderly are due to a viral cause? B, the proportion of meningitis cases involving the elderly is increasing? C, cellulitis complicated by diabetic ulcers or pressure ulcers are usually due to group B strep? D, post-herpetic neuralgia status, post-herpes zoster infection is rarely seen in the elderly? Or a right middle lobe infiltrate on chest x-ray in a 75-year-old patient who lives at home alone with a history of end-stage renal disease on dialysis is considered community-acquired pneumonia and can be treated with Zithromax 500 milligrams twice a day for 7 days. So we're looking for which one's true. Good, okay. So we have most people thinking B and somebody thinking C. Okay, so why is this topic important? By 2020, patients aged 65 years old and older will constitute 16.3% of the population. Already, they account for over 15 million emergency department visits each year, and a large percentage of these visits are related to infection. Fever is present in 10% of all elderly emergency department patients. The elderly account for 65% of emergency department patients with sepsis. Elderly patients are at significantly greater risk mortality for a given infection than are younger adults. Elderly patients have 3 times the mortality from pneumonia and 5 to 10 times the mortality from urinary tract infection when compared with younger adults. These statistics make appropriate evaluation and treatment of the infected elderly an essential skill. The clinical presentation of infection in the elderly is often atypical, subtle, and elusive. This makes early diagnosis and initiating treatment a challenge. Elderly may not only have fewer symptoms, but might present with nonspecific consequences of infection that on the surface appear unrelated. Examples of nonspecific symptoms: general malaise, falls, change in mental status or cognitive impairment, and anorexia. The classical manifestation of infection, fever, and leukocytosis may be absent or blunted in 20 to 30% of serious elderly infections. In contrast to the young, where fever is commonly attributed to a viral process, in the elderly it is associated with severe bacterial infections. It's important to note that criteria for fevers in the elderly are unique and include elevations in body temperature from baseline of 1.1 degrees Celsius or greater. So again, important to know what their baseline is. Mostly that's going to be for your nursing home patients. Furthermore, hypothermia, a decrease in body temperature, is not an uncommon presentation of an underlying serious infection. Okay, so let's talk about influenza. We had a pretty crazy flu season. I don't know how you guys felt, but I hated working in the ER in January this month. It was painful. Although it affects all age groups, influenza causes the most severe disease in the elderly population. Advanced age is associated with increased rates of influenza-related hospitalizations. And again, there's no data to support my Dr. Greenberg theory, but for me, your age equals your % chance of admission from the time that your little name pops up on the PISA system. 90% of deaths related to influenza occur in patients aged 65 years and older. As is true for pneumonia, the elderly may fail to demonstrate the classic signs. For example, many will not have fever or cough. These are the people that are just coming in, they feel run down, they feel exhausted, and then maybe you put your stethoscope on them and their lungs sound like a washing machine. But they don't really come in saying, flashing influenza. They don't have that fever, they don't have the cough, they just feel run down. Secondary bacterial pneumonia may occur and is most commonly caused by strep pneumonia, Staph aureus, and Haemophilus. So even though we're saying mostly watch out for the Staph aureus because you need to tailor your antibiotics, especially with the MRSA. Other things can cause it though. So it can be strep pneumo, it can be Haemophilus. You always want to think Staph aureus though as well, so that you make sure you get your appropriate treatment on board. What is the treatment for influenza itself? You have your Tamiflu and your Relenza. They're recommended first line. However, Relenza is inhaled and may cause bronchospasm in patients with underlying lung disease. So obviously the go-to drug was Tamiflu. Pharmacies didn't even have it this winter. Tamiflu has to be renally dosed. So you got to keep that in mind if you're admitting your patients or if you're sending them home. Tamiflu is given in the usual adult dosage of 75 milligrams orally twice daily for 5 days. Tamiflu has to be renally dosed for patients with a creatinine clearance less than 30, and then there's a recommended once daily regimen for those with clearance of 10 to 30. Amantadine and Ramantadine are not recommended due to the emergence of viral resistance as well as increased side effects in the elderly, particularly central nervous system side effects with Amantadine. And I think we know that. I think that we all jump to Tamiflu, but this is the updated literature that we're presenting. Amantadine, Ramantadine, no. Due to the severe systemic effects and the severity of the respiratory illness, many elderly patients with influenza will require admission. For those patients being discharged, close follow-up is essential. If you're thinking about discharging these patients, I would probably reach out to the family doctor, make sure there's a family member in the emergency department that understands the instructions, what to look for. In my opinion, if they're sick enough, bring them in. Yearly influenza vaccination is recommended for all adults aged 50 years and older. Influenza vaccination of the community-dwelling elderly is associated with a 27% reduction in the risk of hospitalization and a 48% reduction in the risk of death. We sort of missed the mark this year with the flu vaccine, but when it works, it makes us ER people a lot happier because it keeps the patients out. We still want people to get vaccinated, absolutely. Only the trivalent inactivated vaccine is approved for elderly patients. The live attenuated intranasal vaccine should only be used in healthy persons aged 5 to 49. So for the sake of our talk, we're talking about the flu shot, not the intranasal spray. Pneumococcal and influenza vaccination programs have been successfully implemented in the emergency department setting. Given the proven benefits, emergency department physicians should consider offering vaccination to all appropriate patients. And this does get done. That's part of that whole triage process that the nurses go through. Are you up to date with pneumonia? Are you up to date with influenza? So it is something that's happening. I'm going to switch gears here. So question 4 again. So this is the 68-year-old female diagnosed with influenza a week ago. Now she has fever, cough, and pneumonia by chest x-ray. So which of the following is the most likely cause of the patient's pneumonia? What are you guys doing? The answer is Staph aureus. Are you guys hitting the wrong button, or we're miscommunicating?
I mean, you're saying that all 3, but we have to look out for Staph aureus because that's the most common, or strep pneumonitis is the most common?
So the most common is Staph aureus. Right. Okay. So the most common is Staph aureus, but strep, pneumo, and Haemophilus are part of the list. Okay, good. Communication's good.
The slide that you had, I think it had strep listed first, then staph, then Haemophilus. That's why I think there's some confusion with this.
Oh, I gotcha. Okay, I gotcha. Okay, so cellulitis. Cellulitis is more common, more severe, and is associated with increased mortality in the elderly compared with the younger population. Cellulitis in the elderly can often be attributed to chronic venous insufficiency, peripheral vascular disease, malnutrition, and trauma. The microbiology is usually due to beta hemolytic streptococci or Staph aureus. However, cellulitis complicated by diabetic ulcers or pressure ulcers may have different etiologies and include polymicrobial flora, Enterobacter, and anaerobes. So we're talking about your healthier elderly patient that presents with cellulitis. It's more going to be strep or staph, and that's when you're using your penicillins, your cephalosporins, maybe even still your Vanco with MRSA in this day and age. But then when you get these complicated diabetic infections, that's when you're definitely doing your 2 drugs to cover a polymicrobial infection. So that's the distinction that we're making here, healthy versus diabetic. Just some different specific types. Orbital cellulitis is another exception and may be caused by strep viridans and gram-negative bacteria. I think we all know that orbital cellulitis absolutely gets IV antibiotics and absolutely gets admitted, okay? External otitis is generally observed in the elderly and is caused by gram-negative bacteria, specifically Pseudomonas. So that's your malignant external otitis that we're talking about. Again, definite IV antibiotics, definite admission. It's been widely established that bacterial resistance is on the rise. MRSA is an example of such resistant bacteria and is more likely to occur in the elderly population. Once colonized with MRSA, the rate of MRSA infection increases up to 25%, as does the risk of mortality. So that means that once you're colonized with it, if you get another infection with it, your mortality is higher. Your risk of getting another infection with it is higher. Treatment is dictated by what you think the suspected organism is, where the location is, your underlying comorbidity such as diabetes, and obviously the severity of the infection. So if you think that it's methicillin-sensitive Staph aureus or streptococci, you can do a first-generation cephalosporin. You can do an anti-staphylococcal penicillin, and you can do clindamycin in penicillin allergic patients. So these might be the patients that you're thinking oral therapy and can go home, and you're doing your Keflex, your nafcillin, your clindamycin. If you think that they need admission, but it's more likely one of these lesser bacterial infections, you can try like your IV Ansef or your IV Clinda. For For your polymicrobial infections, so your diabetic patients, something that's smelly, stinky, broad-spectrum antibiotics are indicated and must include coverage for gram-positive and gram-negative aerobes and anaerobes. So this is a 2-drug combo: Zocin, Vanco, Rocephin, Vanco, however you guys want to work it out. 2 drugs. Specifically for MRSA, you have to have your Vanco on board, your Zyvox on board, and occasionally you can use Sinercid. I haven't used Sinercid. I don't even know if it's on formulary at Virtua. Because if there's some problem with Vanco, then I just go with Zyvox. Let's talk about meningitis a little bit. I've actually given talks about meningitis. For some reason, it seems to find me a lot. And in my opinion, it is a disease of the elderly now. We do see a lot of kids at Virtual Marlton. I haven't diagnosed meningitis in a teenage patient or a child in like 4 years. All of my cases of meningitis now are in adults. Although the overall incidence of bacterial meningitis in the United States has decreased because of all of our vaccinations, the proportion of cases involving the elderly is currently increasing. The recognition of meningitis in the older patient may be more difficult, but as emergency physicians, we must maintain a high level of suspicion and consider bacterial meningitis as the etiology of acute illness. Higher mortality figures are seen in elderly patients with meningitis, with case fatality rates averaging 20 to 25% for pneumococcal meningitis. And that's usually what they have. They usually have strep pneumo as opposed to Neisseria. Older patients who have severe neurologic impairment at presentation show morbidity and mortality rates approaching 50%. And a lot of times by the time they get to us, because their complaints probably have been subtle, they're more falling into this category. The most likely organisms to cause bacterial meningitis in the elderly are strep pneumo, Neisseria, Listeria, Haemophilus influenza, and gram-negative organisms. And again, this slide is important because we know that we start our antibiotics right away before CT, before LP, and it's your combination of Rocephin plus Vanco plus or minus ampicillin plus or minus acyclovir. Classic presenting symptoms of meningitis include fever, headache, neck stiffness, and photophobia. Other commonly encountered symptoms include lethargy, malaise, altered sensorium, seizures, vomiting, and chills. Although the older patient may exhibit any of these signs and symptoms, they are less often noticed on presentation. Fever is a less frequently encountered finding when compared with younger patients, and nuchal rigidity is not universally present. I would say that nuchal rigidity is not likely to be present. I've only seen a couple cases of true nuchal rigidity, so your suspicion has to be high. Altered level of consciousness, respiratory symptoms, and seizures are more often found in elderly patients when compared to younger individuals. And that's usually because the disease has gone on for a while, so they're sicker by the time they get to you. Among elderly patients admitted with meningitis, risk factors for death were found to be age over 60, obtunded mental status on admission, and seizure within the first 24 hours. So these are the patients that you really have to jump on. Get their antibiotics on board, get their Decadron on board if you're a Decadron believer, all of that before their lumbar puncture. How do we treat it? The objective, so again, we're talking about our older patients with bacterial meningitis, prompt diagnosis and early institution of antibiotic therapy. That's the only thing that's been shown to prove in patient outcome, and that's on us. If we miss this diagnosis in the ER and you admit them and you didn't go down the right path, their morbidity and mortality rises. So we talked a little bit about this. You want to do a combination of multiple drugs. So you want to get your third generation cephalosporin, probably ampicillin because that's what treats listeria. Okay, initial therapy. That combination will be effective against strep pneumo, listeria, aerobic gram-negative bacilli, Haemophilus, and Neisseria. Then you've got your plus or minus vancomycin for staph, and plus or minus acyclovir in this population for their herpes encephalitis. The use of dexamethasone in the management of bacterial meningitis remains controversial. Dexamethasone, when given, should be administered 15 to 20 minutes before the first dose of antibiotics. I don't really think that happens. I think it probably gets done at the same time. I'm not physically in the room watching how it goes. It's my opinion with the Decadron that it can't hurt anything. I don't see the benefit in withholding it. I think that right now there's no clear data either way. If anything, it does decrease the potential for some of your neurologic complications down the road once you recover. So this is something that I'm still doing. And I think for right now, it doesn't do any harm. So you're thinking antibiotics and Decadron together. Talking about prophylaxis, all people who have had close contact with patients diagnosed with bacterial meningitis should be considered for prophylaxis. Your choice is rifampin, 600 milligrams 2 times per day for 4 doses. That'll be adequate protection for Neisseria. You can also use Cipro, 500 milligrams orally as a single dose. Talking about Neisseria, when you have patients with strep pneumo, we as their caregivers don't need to be prophylaxed. It's Neisseria is the one that's really contagious if you're in the same room, breathing in their coughing, their sneezing. Have you guys heard about this outbreak in New York right now among gay men? So supposedly right now in New York, they have a huge outbreak of Neisseria meningitis, specifically among men having sex with other men. I got that through my Trenton job because I guess it's a closer proximity. And there's a case in Princeton right now too. So hopefully it's not working its way down here, because I think people come to the ER and they think, oh, I have meningitis, but they don't realize that you need a spinal tap to diagnose it. And then when you tell them what they're in for, they say, well, I don't want that. So hopefully it'll stay central Jersey and New York. Talking about herpes zoster infection. This is actually a really common disease that we see in the elderly, more frequently in the elderly as well. This disease is interesting because it's confined to the skin and nervous system. It's caused by the reactivation of the varicella zoster virus. So varicella zoster virus is responsible for pediatric chickenpox, and it remains dormant in the dorsal root ganglia. When it reactivates, what reactivates the varicella virus remains unclear. However, it's usually a disease of the elderly and the immunocompromised. As cellular immunity decreases with aging, the incidence of herpes zoster increases. I don't know, are you guys young enough that you had chickenpox, or have you guys all been vaccinated? Okay. I had it too. So what you get is you get pain and paresthesias over a particular dermatome that usually precedes the characteristic rash. So when you don't see the rash and they're just coming in with that pain and paresthesia, it's a little tricky, because it's a lancinating pain. So you might think that it's cardiac pain, you might think it's abdominal pain, you might think it's like renal colic. It's always preceded by that pain and paresthesia, and then the rash comes out. And you can have those symptoms that last for several days before the hallmark lesions. These are the patients that come back to the ER and say, well, you guys misdiagnosed me 2 days ago, because they come in with that pain and paresthesia, somebody's unsure, and then you look like the rock star 48 to 72 hours later when they have the classic rash. So just kind of an example, that dermatomal pattern, it's always just on one side of the body. It doesn't cross the midline, and it's in a specific body part. It's a clinical diagnosis. You can try to do laboratory confirmation. You can do a culture of the vesicular fluid, or by observing giant cells on a Sank preparation. I don't really think that any of us do that. I think that it's a clinical diagnosis, and you stick with it. So one of the problems with herpes zoster is the long-term sequelae of post-herpetic neuralgia. And the incidence of post-herpetic neuralgia increases with age. So about 50 to 75% of patients greater than 70 experience chronic pain over that involved dermatome. And so the problem is it's painful. A lot of times once they get over the initial outbreak, they have this lingering pain. So antiviral therapy initiated within 72 hours of symptom onset decreases viral replication, nerve damage, duration of the eruption, and pain. Administration of therapy after 72 hours may reduce the incidence of post-herpetic neuralgia, but will not impact on the duration of symptoms. So I think this slide is important because what it's saying is it's saying treat them. Okay? If they present to you greater than 3 days out, it's not going to make their rash go away sooner. It's not going to make them feel a whole lot better, but it's going to make their long-term prognosis better, that maybe they won't have post-herpetic neuralgia, maybe they'll have a better recovery. So I think that's a different mentality. We used to say, oh, it's past 72 hours, there's nothing we can do for you. What we're saying is it's worthwhile to put them on a course of acyclovir or Valtrex. What are your choices? Acyclovir, valcyclovir, famciclovir. You know, most of the elderly patients are going to have insurance. They're going to have Medicare. Acyclovir is cheaper, but you have to take it 5 times a day. Valtrex is more expensive, but it's only 3 times a day. So I think for the elderly, we're doing Valtrex. It's just worthwhile to think about. Okay, so this was our question regarding infection in the elderly. Which of the following statements is true? I'm not going to read them again. You guys can pick. Good? Let's see. Good. Who hit the wrong button? Fess up. No, I'm just kidding. Good. Good. E is not right, just in case. That's not considered community-acquired pneumonia. That's healthcare pneumonia. It needs something much stronger than Zithromax. Okay. And this is just the last topic that we're going to hit on for this part. Have you guys heard about this? This quote-unquote nightmare bacteria spreading in U.S. hospitals and nursing homes. I got this through a couple sources. I got this through Medscape and the ACOEP newsletter, if you guys get those in your emails. And I think I got 3 or 4 different emails about this in the same day, and it made me think of this topic. Basically, right now, 4% of U.S. hospitals and 18% of nursing homes had treated at least one patient with a carbapenem-resistant enterobacteria, so CRE. So now we have VRE and CRE. CRE are in a family of more than 70 bacteria called Enterobacter, which includes Klebsiella and E. coli that normally live in the digestive system. And we know that we see Klebsiella and E. coli very frequently. Okay, we don't know it in the ER, but when you look up their cultures when they come back, it's a Klebsiella UTI, it's an E. coli UTI, it's Klebsiella in their sputum, it might even be E. coli in their sputum. So in recent years, some of these bacteria have become resistant to the last resort antibiotics known as our carbapenems. Although the CRE bacteria are not yet found nationwide, they have increased 4-fold within the US in the past decade. And look at this, with most cases reported in the Northeast. And where do we live? In the Northeast. Okay? It's always something in the Northeast. Okay? Most CRE infections to date have been in patients who had prolonged stays in hospitals, long-term care facilities, and nursing homes. The bacteria kill up to half the patients whose bloodstream gets infected. And basically what they're saying is none of our antibiotics work against it right now. Zocin, cefepime, they're basically saying that new antibiotics are needed to treat this infection. And drug companies aren't just going to say, hey, let's create a new bacteria for this 4% of the population that has it. What they've been trying to do is they've really been trying to contain it in the facilities where they know it exists. But if this bacteria starts to have an outbreak, we're going to be in trouble because there's no treatment for it right now. All right, so happy little geriatric couple, how to keep our geriatric patients looking like this. What we want to do, evaluation and management of the elderly patients with infection in the emergency department presents several challenges to the emergency physician. Elderly patients often present without classic signs and symptoms of infection, requiring vigilance in the face of nonspecific symptoms such as confusion or decreased functional status. These patients are at higher risk of poor outcomes than our younger adults. They are also at greater risk of infection with resistant organisms, necessitating the empiric use of broad-spectrum antimicrobial agents. Consideration of these unique aspects of the infected elderly patient will aid the emergency physician in providing optimal care to this at-risk patient population. And that's it. Thanks, guys. Questions, comments? Do you guys learn something? Good. I learned something too. Yeah, for sure. Yeah. All right, good. I don't know, how many spinal taps are you guys doing on your elderly patients these days? Not much, yeah. I agree. It's always kind of in the back of my head when I'm treating these patients though and they don't have like the UTI or the pneumonia I'm looking for. Is it bacteremia? Or, you know, meningitis is kind of always in the back of my head. It's really hard to tap elderly patients though. They don't bend. Their spaces are hard to get into. But I have to say, the cases that I've had, they're all 50 years and older. You guys are doing your pediatric rotations. Are you guys seeing it in kids? Viral meningitis, right? Yeah, we're still going to see viral. So obviously the vaccines are working. You know, it's hard to believe that we still have all these controversies over vaccines too. But thanks.